Hello everybody, welcome back. This is Dr. Marc DuPéré in Toronto, Canada from the Visage Clinic, Plastic Surgery. Welcome. This is a very nice young lady who I'm thanking in passing for agreeing to this filming. A young lady who came to our office a few months ago for breast augmentation. As everybody knows, breast augmentation is a very common and by far probably the most common procedure in a plastic surgery office. She came to us for augmentation. She's had one child in the past. Fortunately, she did not have sagginess or true sagginess of her breast, but she had marked deflation. Her folds were also asymmetrical. Her right side was much lower by 12 millimeter compared to the left side. And to complicate the matters slightly, she had a scar here, which was from cartilage graft or rib cartilage harvesting for rhinoplasty. So she had a scar that was just slightly lower than I like for my breast augmentation, but I did not want to give her a second scar. So what we've done in her situation, I've used her lower scar, I cut it out, and I made a new one, and I raised her fold to match the higher here, which was more youthful. I anchored the new fold with several stitches to the periosteum, which is a thick, strong membrane around the bones. And that allowed me to secure the fold where I want, to put the scar in the fold, and to match her left side. This is what we call the no-fly zone. This is 15 millimeter on each side of the midline, which we do not violate in the dissection. It's very important. We do want a nice cleavage, and when we get this, we get a nice cleavage, but we do not want to disinsert the pectoral muscle here, as it would lead to this lifting of that skin and a unibrow of the breast, which is called symastia. So when this bridge lifts up, it's not aesthetically pleasing and somewhat difficult to correct. So it's important to respect that zone, the no-fly zone. As with all our patients, we do follow the 14-step no-touch technique in breast augmentation in order to minimize the risk of capsular contracture. One of the complications with breast augmentation, which is not dangerous, it's an aesthetic problem, is when the body makes normally a layer of collagen around the implant called a capsule, but in 1, 2, 3% of the cases, over time, months and years, the capsule may contract and deform a gel implant or a saline implant. When this happens, most of the time the implant is pushed up or sideways, and we need to go back and remove the capsule. So one theory is to follow the 14 steps where we minimize any, actually there's no touch to the implant. And you've seen me using the Keller funnel. So we use a Keller funnel to propel the implant through the incision, so the implant does not touch my nurse, doesn't touch me, doesn't touch the table, doesn't touch her skin, doesn't touch her nipple. The nipples are covered here not just for the filming, but it's also to prevent any bacteria from our breast ducts to contaminate the field. We do a bloodless dissection, which is very important. So in the old days, breast augmentation was done relatively quickly. Nowadays, it's a 2.5 hour in my practice where the dissection is done gently, bloodlessly, so that there's no blood around an implant. Blood around an implant is known to cause capsular contracture. Other steps in the 14-step approach is to use IV antibiotics to clean the pocket with antibiotics, triple solution, the Keller funnel. We like also to go under the pec muscle whenever possible. And although she's had one child before, there was no true ptosis or sagginess. So this augmentation was done with 325 cc implant subpectoral muscle using the Keller funnel and the no-touch technique. Breast augmentation, again, is one of our most common procedures here at Visage Clinic. And I want to thank my patient again for agreeing to this filming. Thank you for watching. Have a lovely day.